1 second. All right, you guys, what are you seeing? The presentation mode? Is that okay?
We're seeing presenter view.
Presenter view, thank you. All right, I think this will work fine. All right, hope everybody had a nice weekend. All right, this is a tracing from my friend Dr. Savley in Vietnam. This is a 10-month-old who came into the hospital with heart failure, a low ejection fraction. And the question is, what is the diagnosis and what is the treatment? So I'm going to ask Dr. Barris if he has any thoughts on this.
All right, so let's talk about diagnosis first. This looks wide, especially for a 10-month-old.
Yep.
So I'm talking about a wide complex tachycardia. I'm starting with VT unless proven otherwise. For a patient like this, I do feel like I see P waves after the QRS complex. I feel like I could see them in 2. If you look at that, like the second B, third, I feel like I could see P waves afterwards.
I guess you're referring to these little blips here, is that?
Yeah.
Okay. So you are arguing for ventricular tachycardia, is that right?
Yes.
And do you have any thoughts on the particular type of VT?
Well, we're upright in V1. I feel like for our VOT, we would be. I feel like for our VOT initiated tachycardias, we would be down in V1.
I think you're right on that. Yes. So
I'm going to say not that for our mechanism. There's some, if you have like scar tissue, you could have reentrant VT.
That's true, although generally 10-month-olds won't have that, right? Scar tissue.
I guess in terms of, and I'm just thinking about other types. For Belhassen's, there's like a right bundle and a left axis deviation. So I'm looking at the axis though, where down in 1, we're up in AVF, equiphasic in AVR.
So this is an LVVT, right? Because it's a right bundle. So this is an idiopathic VT, or first described in Israel by Bernard Belhassen. And what Dr. Belhassen and his group showed was the nice response that these often have to verapamil. This is a tracing of the same patient, of a patient in whom verapamil has been given IV, and you see that starts at this rate, gets a little slower still, and eventually converts to sinus rhythm. And it's a description of a single patient. So it's first described in 1981. It's usually the left posterior. Remember, there's an anterior and posterior fascicle on the left side, and it's usually a posterior fascicular tachycardia. Patients are usually otherwise healthy, and the mechanism is believed to be reentry. And it usually is unresponsive to adenosine, vagal maneuvers, or lidocaine. It often responds to verapamil. Amiodarone can be effective, procainamide can also be effective. So basically, Dr. Savely asked me what I thought we should do about this. So I'll ask you. I will tell you they gave adenosine, which did not, to their appreciation, have any effect. Do you think that if you gave adenosine to this patient, David, what would happen to the surface ECG?
So you would, I think that so those little P waves that we see would probably not be as apparent, but otherwise the rhythm should be pretty much the same.
So in other words, you're saying, to rephrase what you're saying, you think there would be ventriculoatrial dissociation.
Yes.
Right. And in fact, I think you could even argue that in V1, there may be VA dissociation here, right? It doesn't look consistent in the in these other leads here. So so they gave adenosine. So this would be important to show, like if you thought this could be some form of weird SVT with aberration, you would want to at least run the strip while you're giving the adenosine in order to see if you can identify a change. You know, the absence of a termination of the tachycardia isn't the only thing we're looking for. For example, if you had seen the ventriculoatrial dissociation, the diagnosis of a primary ventricular arrhythmia would be much more likely, right? Okay, so you've given adenosine. To your knowledge, nothing's happened. So what else could you do, Dave?
So we just talked, I mean, so if the patient was hemodynamically unstable, we could defibrillate the patient, or synchronize cardiovert the patient.
Mm-hmm. And if you were going to synchronize cardiovert the patient, how many joules per kilo would you give this patient?
2 per kilo.
Right, give 2 joules per kilo because this is VT, not SVT. Very, very important. Okay. Now the patient though is in heart failure, but is awake and all. So how would you do that? Would you just cardiovert the patient awake? Would you call for anesthesiology? How would you practically do this?
I think either the ICU team or anesthesiology in order to sedate the patient.
Right,
Would be
exactly. In this case, the doctors in Vietnam, I think, gave amiodarone first as an initial bolus, and that did not work. And following that, they cardioverted the patient. And that also, apparently, they said it temporarily terminated it, but it resumed almost immediately. And so at that point, I received an email in my box at like 6 a.m. asking me what I thought I might do next. And I said I would probably give more amiodarone. What happened apparently was the patient developed cardiovascular collapse with that next dose, requiring intubation, mechanical ventilation, dopamine, and epi. So amiodarone was discontinued temporarily, and I suggested that they resume it at just a continuous infusion. They weaned all the inotropes, and I suggested that they just allow the amiodarone level to slowly rise over a period of 1 to 2 days and then try to cardiovert again. Or if it didn't terminate on its own. And so 2 days later, they cardioverted, and this was the ECG. So what do you think about giving IV verapamil to this child? We just talked about how in Belhassen's tachycardia, verapamil is often effective at treatment of LVVTs.
So I think at a 10-month-old, we wouldn't use it because it could also lead to a severe cardiovascular collapse because they're so sensitive to the calcium channel blocker.
That's right. It could be very dangerous. I once had a patient who had this type of tachycardia, and patient was given a dose of IV verapamil and did have a cardiovascular collapse. So verapamil, one of the problems with verapamil, we've discussed this in the past, is that it comes in a concentration for IV that is very high for a baby, meaning it's very difficult to give very small doses of verapamil. And so the volume ends up being really, really, really tiny. And even if you dilute it, say tenfold, it's still only like 5 mLs. And so it's, in a perfect world, you'd want to give the verapamil like over an hour or at least over 30 minutes. So it's very hard if you're manually injecting it to do that, because then what happens is you push it in, invariably you do it over 8 minutes because it feels longer. And then there's a lot in the sheath or in the catheter. So then you flush that and then boom, the patient arrests. Another option might be, if you're bold, is to potentially use diltiazem. In our paper over 20 years ago, in which we talked about diltiazem use in children, we did have 1 or 2 patients under the age of a year who received diltiazem successfully. I think the key with all these calcium channel blockers, well, first of all, you should probably never, you should never use verapamil in a child under a year of age, mostly because at this point it's contraindicated. It would probably be medical legally inappropriate, although some have suggested that if it were given slowly enough, it might not be as big a deal. But diltiazem also probably on a perfect world shouldn't be used at this age, but we have used it on occasion at this age range without untoward event. But again, the key, I think, is delivering it very, very, very slowly. But diltiazem also can sometimes work to treat this. So if you're on amiodarone, what would you expect? So now you're in sinus rhythm. The family is pleased about this. So what are you going to tell them, David, in regards to the natural history of what you should expect or what they ought to expect?
So, I mean, if there was some sort of, again, if there's some sort of scar tissue that was leading to this reentrant, then it could be some substrate that won't go away. But I know that idiopathic ventricular rhythms in infants can typically resolve on their own. So I'm not 100% sure.
Well, okay, so you're in sinus rhythm. You're now on a pretty hefty dose of amiodarone. So let's say you're giving 8 to 10 per kilo per day of amio. I think actually this was being given orally because they were very gun shy about the IV given the cardiovascular collapse, understandably. So what do you think is going to happen to the function? So you presented with a pretty low ejection fraction. Is there, what's the chances that if the patient remains in sinus rhythm, that this function is going to recover, or will it not?
I think it's good. I think it will recover.
Yeah, it's like 99% likely that it's going to recover. How long do you think it's going to take?
What about like 2 months?
Well, generally, the general rule of thumb is however long you are in tachycardia usually is a pretty good starting point in predicting how long it will take. It's not a guarantee, but in order for the function to have gotten so bad, maybe that the child was in it for a few days or maybe in a few weeks even, who knows. So yeah, it would take a while and typically would take a month or two. The longest I've ever seen is a patient in whom it took 6 months until it recovered. We had a patient when I was at Montefiore who had presented actually with an EAT and a very, very bad function. And I ablated it successfully, and the function just was not getting better, was on a lot of heart failure medication, needed IV therapy in the hospital, to the point where after about a month or two, when we saw no improvement in the echo parameters of function, the child was listed for heart transplant. And thankfully, it took a long time. There were no hearts available. And by about 4 months out, we finally started to see improvement. And at 6 months, the function had completely recovered and the child was delisted. But it's unusual that you won't see some benefit. In people with very bad tachycardia-induced cardiomyopathy, it can take a while, and it wouldn't be surprising if 1, 2, 3, even 4 weeks later, you almost see no improvement. Sometimes you do, oftentimes you do, but not always. But to take that long is notably unusual. So in this case, we would do that, and then we would hope that this would be there is a theory that these are due to Purkinje cell tumors group in Texas Children's has been a big proponent of this theory, and they've recommended MRIs or even surgery for this. But in my experience and in that of the literature, this often will resolve spontaneously, particularly as is the case with virtually all arrhythmias. The younger you are when you have the arrhythmia, the more likely it is to spontaneously resolve. So this will often resolve spontaneously. So we would be cautiously optimistic that this will all just get better and go away. So, okay, good job, Dave. All right, so this is a 12-year-old, status post an aortic and mitral valve replacement. And this is the electrocardiogram in the postoperative period. So I'm going to ask Dr. Condon what she thinks is going on here.
Good morning. So it looks like the patient is bradycardic, at least at the beginning and at the end, and there are a couple of beats.
And what is the heart rate?
Mm-hmm. So let me just see here.
This is also a trace from Dr. Savley, so thank you, Dr. Savley.
It's about less than 60. Let me just.
Yeah, it's less than 60 beats per minute in the range of 50, 55. Okay. So,
and then, so after the first 2 beats, it looks like the heart rate goes up a little bit. So to about like 100.
mm-hmm. So
20.
What is the rhythm? What's the rhythm on the first 2 beats that we're looking at?
So I think I see a P wave before the QRS complexes, maybe. Is it not? Okay.
There are some beats, I think, where you can see some P waves, right?
Mm-hmm.
Like, what about the last 4 beats on the right side of the tracing?
I don't actually. Yes. So I do see P waves in the last 4 beats.
I don't really think so, Tulsi. Right, looks pretty much. Let's see. I mean, the thing is, right, you could argue that maybe there's a P wave somehow buried in here, but on these beats, we can clearly see that there are some P waves, right? I mean, I think we would agree we see P waves here. So I don't think there's any obvious P waves associated with these QRSs. So what would you call this rhythm? Is it wide or is it narrow?
Looks narrow.
It's fairly narrow for a 12-year-old. So if it's narrow and there's no P waves in front of them, what do we call it?
Junctional rhythm.
I'm sorry?
Is it a junctional rhythm?
Yeah, some kind of a junctional rhythm. And then, so now when you see it, if you didn't have these beats here, if we didn't have these beats and all we had was this and this could be a heart block, right? It's either junctional or a heart block. But those beats in the middle clearly show that when there is a P wave that shows up, there is conduction. So are those beats sinus beats or PACs or both? That's the multiple choice question.
Well, I'm not sure. I would say It doesn't, so the
Maybe-
majority of the beats are junctional. So I would say that if there are P waves that show up, I would choose PACs.
Well, in looking AVL, there's basically two beats that are conducted with P waves in front of them, right? There's
Yes.
this beat here and
Mhm.
this beat, okay?
Mhm.
Is the morphology of these two P waves the same?
Does not look like it.
Okay. Rather than tell me they don't look that way, are they or are they not? This is a yes, no question. Everything
So
kind of is right or wrong, but we want to be definitive. Is this P wave the same as this P wave?
no.
All right, this P wave is upright, this P wave is down going. Similarly, in a different lead, this in lead F, the P wave is upright, and in this, and then here it's down. So these are not the same P waves, right? So
Yeah.
presumably one of them may be a sinus beat and one of them may be a PAC. So it's actually both. So this is sort of a junctional rhythm with rare sinus capture and occasional PAC. So the question then is, what should we do about this? That's actually what Dr. Savely wanted to know, if I had opinion on what this is. Do you have any thoughts on why this patient might have this problem? To be honest, I don't know myself, except to say that, to put a mitral valve in, you have to pull. You have to have very good exposure. You have to make, the surgeon has to make an iatrogenic ASD temporarily. And because they have to make a very big atriotomy. Is it possible that the sinus node was in some fashion injured? Is it possible that this patient had surgery previously and already had some sinus node injury from a prior injury, and then whatever they did at this surgery made it even worse? It's hard to know. So if you're in the ICU and the blood pressure is normal and the patient is well perfused, is there any pacing maneuver you might want to do for this patient? Or do you need to do any pacing for this patient?
If their blood pressure is fine and their perfusion is fine, I don't think so.
Yeah, that's right. You wouldn't necessarily need to treat this. But if the patient was, maybe not diuresing well and slightly low output, would you pace the atrium, or would you pace the ventricle, or would you do dual chamber pacing? What do you think would be, if we were going to guess, and we don't really know, but if you were going to guess what the best approach to pacing this type of patient would be in the post-op period? What would be
sorry.
Go ahead, I'm sorry.
It's okay. I'd pace the atrium.
Yeah, pace the atrium, because it appears as if conduction is okay, right? We see two conducted P waves. So probably we would just pace and maybe pace at a slightly more robust level, right? To have a heart rate of 50 or 60 when you're hemodynamically fine, have normal function, just resting on the couch isn't a big deal. But in someone who just had a big surgery to replace their aortic and mitral valve, they might need a little bit more heart rate, a little more cardiac output than they have. And so probably in a patient like this, we might recommend at least temporarily pacing the atrium to get a slightly faster atrial rate, on the hope that over time, as more days go past from the day of surgery, that the sinus node will improve and recover. So I think that that's what I would generally do. Let's go to this. Okay, so I found this website that asks some board questions. So since we have a few people who will be taking boards not too far in the future, I thought I'd go over them from the Thoracic Key website. So a newborn presents with a narrow complex tachycardia. Adenosine is given, a change in the heart rate noted as in the rhythm strip, which we're looking at. What is the most effective method for terminating the tachycardia? Is it oral amiodarone, oral digoxin, IV amiodarone, oral propranolol, or direct current cardioversion? So I'm going to ask Dr. Alfaturi which of these he would choose.
Good morning.
Morning.
So here it looks like the rhythm converted into how it's called an atrial flutter.
Yes, this is atrial flutter, neonatal flutter. What's the atrial rate about, roughly?
I would say maybe 150 or 140.
No. So they give
No.
adenosine, and these are the P waves, right?
No, actually, it's almost like 200. I would say to 250 maybe.
Even more than that, right? It's more like a rate of 300.
Yeah,
right?
300. Yeah, I would say
Even
300
faster,
or
even
330.
faster than 300. Is that a
it's
normal?
faster.
Is that a normal atrial flutter rate for a newborn?
I think the atrial flutter would be around 200, normal one.
No, actually, in newborns with atrial flutter, the atrial flutter rate is usually very fast, often as fast as 400 beats per minute. So this is actually a very nice example of a very typical type of atrial flutter that we sometimes see in newborns, a very fast flutter rate with 2-to-1 or 3-to-2 conduction to the ventricle. The ventricular rate is over 200 or close to it. It's actually closer to 200, but the atrial rate it's essentially 2-to-1 is what we're seeing on the left-hand side, and then they give adenosine. Really didn't need to give adenosine in this tracing, right? If all you had was this part of the tracing, I think we would all agree that we see quite clearly 2 P waves for every QRS. So this is atrial flutter. So this is a typical rate. So Mahmoud, you're in the neonatal ICU. This baby is a few hours old, and this is what you are shown. So which of these choices would you pick? Which is the correct answer? Oral amio or DIG or propranolol, IV amiodarone, or direct current cardioversion?
So I wouldn't do any of the oral.
Okay.
I'll be either between IV amiodarone or direct cardioversion. Before I'll take the decision, I'll definitely consult someone who's more senior or more experienced.
Okay, you're allowed to answer that since you're still a resident and not a fellow.
Okay.
Let's call Dr.
I would do.
Let's do a phone a friend to Dr. Bonsall. See what if she could offer you some advice from her senior perch as a senior fellow.
Good morning.
Good morning.
I would DC cardiovert.
You're a DC cardiovert. Okay, I agree with that answer. That is the correct answer. Mahmoud was using game theory to answer the question. Prerna was using cardiology knowledge. Prerna, how would you practically do this?
So this is neonatal atrial flutter, so it responds very well to DC cardioversion. Practically, we would do a 0.5 joule. I'd start with 0.5 joule per kg of the.
Would it be synchronized or asynchronous?
Synchronized cardioversion.
Right. And what are you synchronizing it to? The atrium or the ventricle?
The ventricle to the QRS complex.
Exactly. And does the baby need to be sedated, not sedated? How would you do this?
Sedated, always sedated.
Always sedate somebody when we cardiovert them. Right, so you sedate the patient and then cardiovert the patient. Now, the patient is successfully cardioverted, and you go out to the family and you say, I have just cured your child of atrial flutter. And then the family says, well, doctor, what is the chances this is going to come back? Is this going to be a long-term problem for my baby Pebbles? And you have to answer, what is the answer? What are you going to tell the parents of little Pebbles in terms of what's going to happen to them?
How you chose Pebbles.
But I would choose a cartoon name today.
So it's very rare that it recurs, and I think it is more than 85% that it never recurs. And then once we have DC cardioverted, then you don't need to start them on any medication. You obviously monitor them in the ICU, and if it goes away, then it just goes away.
That's generally correct. Yes, I agree with that. All of what you said, it's usually the case. So you can be very reassuring that their child Pebbles will have a very successful cartoon career. Very good. All right, let's move on to this next question. A patient who presents for a routine sports physical is noted to have LV septal hypertrophy on his echo, consistent with hypertrophic cardiomyopathy. Which of the following additional factors most increases the risk of sudden death? Is it A, marked hypertrophy on the ECG, B, LV septal thickness of 1.7 centimeters, C, LV outflow gradient of 20 millimeters of mercury, D, family history of multiple sudden deaths, or E, chest pain with exercise? I'm going to ask this question of Dr. Sergey Bebya of Manhattan, New York.
Good morning.
So
I would say we could always blame our parents. So I would say family history of multiple sudden deaths.
very, very Russian answer there. That is correct. Family history of sudden death is a very significant risk factor for sudden cardiac death in a hypertrophic cardiomyopathy patient, and is in the adult criteria is in fact an indication for defibrillator placement. It's not necessarily in children. Normally, we would want to see more than just that in a child, and there are actually there's actually a terrific calculator from the group at in Toronto. I think it's the primacy calculator. If you Google that, it's a primary calculator. It's very nice. It has you can put in the dimensions of your patient's heart and history, and they'll tell you what the risk is for sudden death based on the literature at the present time. So let's go through all of these quickly. LV hypertrophy on the EKG. Is there any criterion by which that is a risk factor in hypertrophic cardiomyopathy for sudden death? Sergey?
I don't know, but I guess not.
Okay, that is correct. LV hypertrophy on EKG is good to sometimes identify somebody with a problem, but there are no criteria showing that that is in and of itself a risk factor for sudden death. If that were true, right, half of our adolescent boys who are thin-walled chest, or especially in African-American children, lots of LV hypertrophy by voltage criteria, which is not actually reflective of actual hypertrophy. Okay, LV septal thickness of 1.7 centimeters. What do you think about that, Sergey? Is there a septal thickness that would get you more concerned?
That sounds right.
Wait, because it's asking which of these is at risk for sudden death. So you're saying septal thickness of 1.7 is there a number that is in fact a risk factor?
I would suggest the thicker it is, the higher the risk.
That's true. Is there a goal?
Don't remember the number.
It's actually 3 centimeters.
3 centimeters.
The line in the sand. Now, in the pediatric literature, they talk about Z-scores. And I think the group in Toronto has used Z-scores, but generally for adult-sized patients, 3 centimeters. And it says septal thickness, but in reality, if there's a thickness of any part of the myocardium of 3 centimeters or greater, that is considered a risk factor for sudden death in the hypertrophic cardiomyopathy patient. So that's an important number to keep in your head. Now, interestingly, I follow a young lady who, when she was a young teenager, went to the Mayo Clinic, and they told her that, you know, her septal thickness was like 1.7, but they basically made some kind of an argument that if she were older, that would be equivalent to being bigger. And so they put a defibrillator in her, which is not really the usual approach. But the bottom line is for an adult, 3 centimeters anywhere. It's not just septal. Septum is the most common place we see thickness, but it can be anywhere. You can have apical thickness, free wall thickness, anywhere that there's a thickness greater than 3 centimeters, that is considered a risk factor for sudden death. What about an LV outflow gradient of 20 millimeters of mercury? Is that a risk factor for sudden death?
I think that I think there is some degree of LVOT obstruction that is associated, but I'm not sure it's 20 millimeters.
So 20 is very low, right? I mean, 20 millimeter gradient is not a risk factor for sudden death. And there are, there actually are no large scale studies showing that these gradients in adults are definitively, there are some studies that show it, but generally LV outflow gradients are not usually considered one of the traditional risk factors for sudden cardiac death in people with hypertrophic cardiomyopathy. There was a study out of Boston from about a year or two ago, which I reviewed on the podcast, in which they did stress echoes on these patients and showed that a lot of them got very high gradients, but it's not at all clear if that is of any benefit or use in predicting risk for these patients. And in fact, I make the argument that it's a dangerous practice myself, I think. But the bottom line is, I don't think we know much about outflow gradients. There are some studies showing it's a higher risk, but generally speaking, surprisingly, does not come out in many larger scale studies. Family history of multiple sudden deaths, even one sudden death would be a very significant risk factor, particularly the closer the relative is to you, but really any relative. When I spoke with Barry Marin about this, I once asked him, does it matter if it's your first degree relative or your second cousin? And he basically sort of looked at me and laughed and said, it's a genetic disease. So if you have it and you have family history, it's the same gene. So your risk should be exactly the same, whether it's your first cousin or your third cousin. And then chest pain with exercise. Is this a risk factor for sudden death, Sergey?
No, I don't think so.
No, that's a bullshit thing. You can get chest pain with exercise in hypertrophic cardiomyopathy. It can be quite disabling, actually, and sometimes it has to be treated with either beta blockade or calcium channel blockade. Sometimes you can have coronary bridging, which could be a cause of this. So chest pain is a symptom that is not rare in hypertrophic cardiomyopathy with exertion, but it is not in and of itself a risk factor for sudden cardiac death. It just sort of is what it is. It's just a factor. So of all of these, really, we did talk about exercise. Is there anything on exercise study, though, that would potentially be a risk factor for sudden death in a hypertroph?
Abnormal exercise blood pressure response.
That's exactly right. An inadequate increase in your blood pressure with exertion is a risk factor. Although of all of the main risk factors, it is the lowest. It has like the lowest relative risk, the lowest odds ratio increase in your risk for sudden death. So it is real, but it is a relatively small risk compared to the other ones. And I don't know too many cardiologists who would put a defibrillator in someone as primary prevention with that as the only indication. Almost always, if you have that, you have something else. And I think with that, we'll stop for today. Thanks, guys, for joining. I will see you at Sinai in a little while. Hope you all have a great day.
Thank you very much.
Thank you.